Hello. So let's start today's session. Yesterday, the last topic we did is was electrophysics. Let's start from erythrocytes. Erythrocytes carry oxygen to tissues and CO2 to lungs, or nucleate and lac organelles. Biconcave, shown in image A, with large surface to area volume ratio for rapid gas exchange. Okay. Lifespan approximately 120 days in healthy adults, 60 to 90 days in neonates. Source of energy is glucose, 90% used in glycolysis, 10% used in HMP shunt. Membranes contain chloride and SCO3 antiporter, which allow RBCs to export SCO3- and transport CO2 from the periphery to lungs for elimination. Red site cell erythrocytosis is equal to polycythemia, increased SCD, and anisocytosis, varying size, poikilocytosis, varying shapes. Reticulocyte is equal to immature RBC, reflect erythroid proliferation. Bluish color, polychromasia. On right, Giemsa stain of reticulocyte presents residual ribosomal RNA. Okay. Thrombocytes involved in primary hemostasis. Nucleate small cytoplasmic fragments shown in image A, derived from megakaryocytes. Lifespan of 8 to 10 days. Platelets, when activated by endothelial injury, aggregate with other platelets and interact with fibrinogen to form platelet plug. Contain dense granules, calcium, ADP, serotonin, histamine, cash as a mnemonic, and ARPA granule, von Willebrand factor, fibrinogen, fibronectin, platelet factor 4. Approximately 1/3 of platelet pool is restored in the spleen. Okay. Thrombocytopenia or decreased platelet function result in petechiae. Von Willebrand factor receptor, GP1B, fibrinogen receptor, GP2B3A. Thrombopoietin stimulate megakaryocyte proliferation. Alpha granules contain von Willebrand factor, fibrinogen, fibronectin, platelet factor 4. Monocytes found in blood differentiate into macrophages in tissue. Mono 1 nucleus, site cell, large kidney shaped nucleus shown in image A. Extensive frosted glass cytoplasm. Okay. Next, macrophages, a type of antigen presenting cell, phagocyte bacteria, cellular debris, and senescent RBCs long life in tissues, differential form circulating blood monocytes shown in image A, activated by IFN, IFN gamma, can function as antigen presenting cell via MHC2, also engage in antibody dependent cellular cytotoxicity, important cellular component of granulomas, that is TB sarcoidosis, where they may fuse to form giant cells. Macro is equal to large, phage is equal to eater. Macrophage naming varies by specific tissue type, that is Kupffer cells in liver, histocytes in connective tissue, osteoclast in bone, microglial cells in brain. Lipid A form bacterial LPS bites CD14 on macrophages to initiate septic shock. Dendritic cells, highly phagocytic antigen presenting cells, APCs, shown in image A, function as link between innate and adaptive immune system, that is via T cell stimulation, express MHC class 2 and FC receptor on surface, can present exogenous antigen on MHC class 1 cross presentation. Eosinophils defend against helminthic infections, major basic protein, bilobed nucleus packed with large eosinophilic granules of uniform size, shown in image A, highly phagocytic for antigen antibody complexes, produce histaminase major basic protein MBP, a helminthotoxin, eosinophil peroxidase, eosinophil cationic protein, and eosinophil derived neurotoxin. Eosin is equal to pink dye, philic is equal to loving. Causes of eosinophilia: Pac-Man eats parasites, asthma, chronic adrenal insufficiency, myeloproliferative disorders, allergic processes, neoplasia, that is Hodgkin's lymphoma, eosinophilic granulomatosis with polyangiitis. Basophils, shown in image A, mediate allergic reaction, densely basophilic granules, shown in image A, contains heparin anticoagulant and histamine vasodilator. Leukotrienes synthesized and released on demand. Basophilic strains radially with basic strains. Basophilia is uncommon but can be a sign of myeloproliferative disorders, particularly CML. Mast cells mediate local tissue allergic reactions, contain basophilic granules, shown in image A, originate from same precursor as basophilic but are not the same cell type, can bind Fc portion of IgE to membrane, activated by tissue trauma C3A and C5A, surface IgE cross-linking by antigen, IgE receptor aggregation, leads to degranulation, leads to release of histamine, heparin, tryptase, and eosinophil chemotactic factors involved in type 1 hypersensitivity reactions. Chromoline sodium prevents mast cell degranulation, used for asthma prophylaxis. Vancomycin, opioids, and radio contrast dye can elicit IgE independent mast cell degranulation. Mastocytosis, rare proliferation of mast cells in skin and or extracutaneous organs associated with c-KIT mutations and increased serum tryptase. Increased histamines leads to flushing, pruritus, hypotension, abdominal pain, diarrhea, peptic ulcer disease. Lymphocytes refer to B cells, T cells and natural killer NK cells. B cells and T cells mediate adaptive immunity. NK cells are part of innate immune response. Round, densely staining nucleus with small amount of pale cytoplasm, shown in image A. Natural killer cells, important in innate immunity, especially against intracellular pathogens. NK cells are larger than B cells and T cells, with distinctive cytoplasmic lytic granules containing perforin and gran enzymes that, when released, act on target cells to induce apoptosis. Distinguish between healthy and infected cells by identifying cell surface proteins induced by stress, malignant transformation, or microbial infections. Induce apoptosis, natural killer, in cells that do not express class 1 MHC cell surface molecules. That is, virally infected cells with these molecules are downregulated. Okay. We just see the diagram. Lytic granules, NK cells, CD56, CD16, FCR. B cells. B cells mediated humoral immune response originate from stem cells in bone marrow and matures in marrow. Migrate to peripheral lymphoid tissue, follicles of lymph nodes, white pulp of spleen, unencapsulated lymphoid tissue. When antigen is encountered, B cells differentiate into plasma cells which produce antibodies, and memory cells can function as an APC, antigen presenting cells. B cells, CD19, CD20, CD21. B is equal to bone marrow. T cells, TCTH, mediate cellular immune response, originate from stem cells in bone marrow but mature in the thymus, differentiate into cytotoxic T cells, express CD8, recognize MHC type 1, helper T cells, express CD4, recognize MHC type 2, and regulatory T cells. CD28 co-stimulatory signal necessary for T cell activation. Most circulating lymphocytes are T cells, 80%. T is equal to thymus. CD4 positive helper T cells are primary target of HIV. Rule of 8, MHC2 into CD4 is equal to 8. MHC1 into CD8 is equal to 8. Rule of 8. Plasma cells produce large amount of antibody specific to a particular antigen, clock phase, chromatin distribution and eccentric nucleus, abundant rough endoplasmic reticulum and well-developed Golgi apparatus, arrows in A, found in bone marrow and normally do not circulate in peripheral blood. Multiple myeloma is a plasma cell dyscrasia. Hematology and oncology, physiology section. Hemoglobin electrophoresis. During gel electrophoresis, hemoglobin migrates from negatively charged cathode to positively charged anode. HbA migrates the farthest, followed by HbF, HbS, HbC. This is because the missense mutation in HbS and HbC replace glutamic acid minus with valine neutral and lysine positive respectively, making HbC and HbS more positively charged than HbA. Okay, got it. A normal adult towards anode cathode origin. AF newborn, normal newborn. AS sickle cell trait. SS sickle cell disease. AC HBC trait. CC HBC disease. HBSC disease. A is equal to normal hemoglobin beta chain, HbA adult. F is equal to normal hemoglobin gamma chain, HbF fetal. S is equal to sickle cell hemoglobin beta chain, HbS. C is equal to hemoglobin C beta chain, HbC. If fat Santa Claus can't cathode anode go far. Okay. It's a Christmas time and we got a mnemonic of Santa Claus. Nice. Okay. Next, antiglobulin test, also called as Coombs test. Detect presence of antibodies against circulating RBCs. Direct antiglobulin test, anti-human globulin Coombs reagent added to patient's RBCs. RBCs agglutinate if RBCs are coated with anti-RBC antibodies. Used for AIHA diagnosis. Indirect antiglobulin test. Normal RBC added to patient's serum. If serum has anti-RBC ABS, RBC agglutinate when Coombs reagent is added. Used for pre-transfusion testing. Does this patient have AIHA? Perform direct antiglobulin test. Direct Coombs. Patient RBC with or without anti-RBC ABS. Anti-human globulin, anti-human globulin Coombs reagent. What will happen in positive? What will happen in negative? Positive AIHA, agglutinate indicates presence of anti-RBCAB. No agglutination, no AIHA. No agglutination indicates absence of anti-RBCAB. Will recipient react against donor RBCs? Perform direct antiglobulin test. Indirect Coombs. Patient serum with or without anti-RBC ABS. Human anti-human globulin and donor blood. What will happen in positive and negative? Positive reaction. Agglutination indicates presence of anti-RBC antibodies. No reaction. No agglutination indicates absence of anti-RBC antibodies. Okay. We are pretty tired as of now. We want to complete these sessions and want to sleep, but I will check phone for some time and then only I will sleep. It's good that we are consistently doing these sessions every day without missing. Let me one few seconds break to drink water. Platelet plug formation, primary hemostasis. They have given it in 5 steps: injury, exposure, adhesion, activation, aggregation. Most likely this is going to be our last page for today. Injury, endothelial damage, transient vasoconstriction via neural stimulation reflex, and endothelial released from damaged cells. Second, exposure, von Willebrand factor binds to exposed collagen. Von Willebrand factor is form Weibel pallid bodies of endothelial cells and alpha granules of platelets. Third, addition. Platelets bind VWF via GP1B receptor at site of injury, only specific. Platelet undergoes conformational change. Platelets released ADP and calcium necessary for coagulation cascade TXA2. ADP helps platelet adhere to endothelium. For activation, ADP binding to P2Y12 receptor induces GP2B3A. Expression at platelet surface. rapid irreversible platelet aggregation. Fifth, aggregation. Fibrinogen binds GP2B3A receptor and links platelets. Balance between pro-aggregation factors, anti-aggregation factors. Pro thromboxane A2 released by platelets, decrease blood flow, increase platelet aggregation. Anti-aggregation factors, prostaglandin I2 and nitric oxide released by endothelial cells, increase blood flow, decrease platelet aggregation. Leads to temporary plug stops, bleeding, unstable, easily dislodged coagulation cascade, secondary hemostasis. Okay, let's read thrombogenesis. Formation of insoluble fibrin mesh. Aspirin irreversible inhibit cyclooxygenase, thereby inhibiting thromboxane A2 synthesis. Clopidogrel, prasugrel, and ticagrelor inhibit ADP-induced expression of GP2B3A by blocking P2Y12 receptor. Etifibatide and tirofiban inhibits GP2B3A directly. Ristocetin activates von Willebrand factors to bind GP1B. Failure of aggregation with ristocetin assay occurs in von Willebrand disease and Bernard-Soulier syndrome. Desmopressin promotes the release of von Willebrand factor and factor 8 form endothelial cells. Von Willebrand factor carries protect factor 8. Volkswagen factories make GR8 cars as mnemonic. Okay, let's see the diagrammatic representation. Vascular endothelial cell, P-selectin, von Willebrand factor receptor, deficiency of von Willebrand disease, Weber pilot body, P-selectin. Injury, first injury, P1 nitric oxide. Okay. If injury it goes there, activated desmopressin, subendothelial collagen exposure, ristocetin get form complex, GP1B deficiency cause Bernard-Soulier syndrome. Okay, then addition, GP2B3A insertion, platelet, this is a platelet. Fourth step, activation of GP2B3A insertion, inhibited by, these are all drugs. No, not all. Desmopressin, ristocetin. Okay, clopidogrel, prasugrel, ticagrelor inhibit ADP-P2Y12 receptor. leads to activation of it, and this drug can inhibit that pathway. Then fibrinogen, inhibited by abeximab, iftifarbatide, tirofiban. Deficiency, Glasman's thrombocythemia. Fifth, aggregation, arachidonic acid, COX to thromboxane A2. COX inhibited by aspirin leads to thromboxane A2 pro aggregation. Okay, and we are done with our today's session. For one last time, let's see what we studied today. We'll call it a day. We started from erythrocytes, thrombocytes or platelets, monocytes, macrophages, dendritic cells, eosinophils, basophils, mast cells, lymphocyte, natural killer cells, B cells, T cells, plasma cells. We started with physiology, hemoglobin, electrophoresis, agglutination test, platelet plug formation, primary hemostasis, and thrombogenesis. So that's it for today. We are very happy we are doing these sessions consistently. See you all in the next session, most probably tomorrow this time.